how many with long COVID do you have in Sweden? Do you know any number?
We don't have the full number actually, but it's yeah, I guess it's 10,000 or more. It's really a large population now, and we see increasing numbers. So we have, I think, yeah, it's difficult to say exactly how many there will be in a couple of years or so.
Yeah. They're starting to emerge now.
Yeah.
Okay. So let's carry on with your next.
Yes, I will do that, and hopefully we will see. Can you see my full slide now?
Yes.
Yeah.
To be continued.
Yes, and now you see the next one, I hope.
Yes.
Yeah. So now we're going to move a bit away from ME, you could think, but it's actually quite connected to what we see in our ME patients, and that's why we have started to look around in other post-viral complications that can hit the central nervous system. And one example, it's a rather rare patient group, luckily. It's patients who have an initial infection with herpes simplex encephalopathy. So it's based on that you get the herpes virus type 1 infection, and many of us know about this. It gives cold sore on your lips typically, and you start to get these if you're immunosuppressed, or if you have another virus that give you a reactivation of the herpes virus, or if you're under stress or sunlight, etc., can trigger this. But what happens in some of the patients, it's not that many patients every year, but a few patients every year get infection that actually penetrates all through the central nervous system. And this is a picture from one of the patients in MRI, and you can see here this patient is severely damaged in the brain by the infection. So here you have the lesions, white parts here should not be there basically, which shows the severity of the disease when it hits the brain. And in a few cases, the patients actually die from the infection by the encephalopathies. We have studied these patients, and we have collected 48 patients, not that many, but that's actually one of the larger cohorts that is available in Sweden and in Europe. And we are studying these patients over time, so we have possibility to draw samples, both blood samples and also cerebrospinal fluid samples over time. And I've just show you one picture of the data set. We have now sent this in for submission for publication. So hopefully will be accepted soon. What we can see is that, for instance, patients that have antibodies producing, or the immune system producing antibodies against NMDA receptors, if they have these antibodies, we know that is a severity factor for the patient. So if they recover after the encephalopathy, they will have maintained fatigability and brain fog and post-exertional malaise, etc., up to 3 months or 6 months or years afterwards the disease. And if you have the NMDA autoantibody receptor, we can also correlate that to different other biomarkers. Like in this case, we have apolipoprotein A1. That is a protein we know that can protect against synaptic autoimmunity. And if you have the anti-NMDA receptor antibodies produced in your cerebrospinal fluid, you actually have a lowered concentration of this protective protein. So it all comes together with the neuroinflammation and activation, then all side effects of the immune system, as you can say. Here you also see the p-values that from the start, in the beginning of the disease, there is not a significant difference between the groups, although the patient group without the antibodies against NMDA receptors are higher in apolipoprotein. It's not significant though. But at time point 2 and time point 3, that is 1 month and 3 months after the initial infection, we can see that separation of the patient groups is clear and significant. So what about long COVID then, and the post issues with the COVID infection? Well, as you maybe have seen, Avindranath at the National Institute of Neurological Disorders and Stroke said already a few years ago that I think the tools we have applied to study ME/CFS can now easily be applied to study long COVID as well, and vice versa. What we learn on long COVID is going to benefit us in ME/CFS, and I think that is true. We can help each other by learning from the different pathways of the pathology, and then learn about potential treatments and also cures for both these diseases. So what we did very early on, when the first patients came to us at Uppsala University Hospital, we started looking at cerebrospinal fluid in the patients that had infectious disease-related neurological issues, neurocognition issues. And we had one patient that came from another hospital that was transported to us in Uppsala, who had an ongoing inflammatory reaction inside the central nervous system that was very pronounced. So the patient had acute necrotizing encephalopathy, so brain was actually degrading due to the infection. And here you see the patient's skull or brain in the MRI scan, and you see that these white lesions here should not be there. So we can say that the immune system has been activated, we get an inflammatory reaction, we get these lesions, and we could also measure in the cerebrospinal fluid, we can measure that the SARS-CoV-2 virus actually penetrated all the way into the central nervous system. Luckily, this is not very common. Most patients don't get any central nervous system issues or very short ones. And if you study patients in MRI, you don't typically see these big lesions as in this patient. However, we know that many of the symptoms in post-COVID group overlaps very much with what we see in our ME group. So general symptoms, tiredness, fatigue, that interferes with your daily life activities, symptoms that get worse after physical and mental efforts. That's what we call post-exertional malaise, fever, cardiovascular problems, respiratory system problems, dyspnea, cough, chest pain, heart palpitations, digestive system symptoms as diarrhea and stomach pain. And what we are most interested in is the neurological symptoms, concentration issues, headache, sleep problem, dizziness, pins and needle feelings. It's quite commonly described that the patient feels in their peripheral organs, like in the feet or in the hands, like pin and needle feeling, tickling feeling in their fingers or feet. Changes in smell and taste, like anosmia or paranosmia. Depression and anxiety is also not uncommon, but it's not a hallmark of the post-COVID symptom. Other symptoms is also joint and muscle pain, rashes, changes in menstrual cycle, hormone regulatory issues, etc., etc. So what we are doing in the post-COVID clinic that we are running now in Uppsala, but also in collaboration with Stockholm region and some other peripheral regions in Sweden, we collect patients and they come to us for evaluation. We look at the outcome, we follow up, and we have now IRB to be able to follow up patients for over 5 years actually. We take blood plasma, blood cells, cerebrospinal fluid sometimes, urine samples. We do viral sequencing, we measure cytokines, measure hormones, metabolomics, proteomics, and transcriptomics. And the whole idea is to see that patients that have come down with a verified COVID infection, how do they recover? And as you know, most patients will recover fully, although it can take more or less a long time, and find those that actually do not recover over the years, to identify the long COVID cohort and follow them, and also see what kind of treatment is possible to use for them. So one thing that we have been studying, this is very preliminary data, but the cerebrospinal fluid samples from patients with herpes simplex encephalopathies, these are the green triangles here. We have compared patients with COVID infection, these are the red spots, and the patients with ME/CFS, these are blue squares. And what you can see in this pattern is that there is a large overlap between the COVID patients and the ME/CFS patients when it comes to proteomics, cerebrospinal fluid proteome that relates to, for instance, inflammation, while the HSE group, herpes-induced encephalopathies, are elevated on many markers, but they don't fully overlap with the two patient cohorts of COVID and ME. So this may be of interest for us to see what are the similarities, but also what are the differences between the COVID and ME/CFS patients group, if there are any. So this is one thing that we are following. Another thing that we have been studying is the occurrence of reactivation and reactivation of viruses. And now we have studied, for instance, Epstein-Barr viruses and herpes viruses, herpes type 6. And in many of our patients with COVID, we see reactivation of Epstein-Barr viruses and also herpes viruses. And when we follow the patient after a certain time period, at the revisit, we see that this activation in some cases actually maintains, but in most cases the reactivation has been suppressed again with immune system suppression. We are now looking into if patients with this maintained reactivation may be the patients that actually have a poorer outcome, and maybe these are the patients that actually comes down with a diagnosis of post-COVID in the end. Turning into imaging and neuroinflammation a bit more then, the rationale for us to look into imaging techniques for post-COVID patients is, of course, both for the sake of the ME patient group, but also to better be able to study long COVID patients. And recently there have been papers coming out where other research groups has found brainstem volume changes in patients with ME and long COVID by using imaging techniques like MRI. And another study that came from Germany, they also seen structural brain changes in patients with both post-COVID fatigue patients, and also compared them with ME patients at some point. And in this study, which I think is very well done and nicely presented, you can see that certain regions of the brain, this region here in the thalamus, here in putamen, and in pallidum in the brain, you see that there is a significant change of brain volume and structural changes after COVID infection in patients that have long-term consequences of the COVID. And this, of course, is very attractive, because then if we can do this measurement, we can have an objective measure of, first of all, the brain volume change and the inflammation that occurs. But we can also have an objective measure for how the patients are responding on treatment, what can be the long-term prognosis for the patient, etc. So this is something that we have been very much interested in studying. And currently we are setting up a new technique for this in Uppsala Academic Hospital Radiology Department. And it's based on a basic MRI camera, similar to whatever you can find at your own hospital. But the difference is that we will apply a new algorithm, an algorithm that takes care of the signal from the MRI camera and identifies changes in specifically the neuroinflammatory reaction in the brain. And we know in preliminary studies, we can actually see that when you have inflammation, you can get certain regions of the brain activated, and you can actually refer the inflammation to activation of the microglia cells, the cells that I talked about earlier, that are resting immune cells, you could say, support cells in the brain, that after activation, the immune system will kickstart these cells and they change their morphology. They start to produce cytokines and they start an initial inflammatory reaction in the brain. So by this technique, we hope we can monitor and look at this inflammation, and then also look at the consequences of the long-term consequence of the patient with post-COVID, but also look at potential treatments where we are going to set up pilot treatment trials for certain inflammatory reaction affecting disease drugs that we are looking at. Oops, sorry. And here you have an MRI scan of the brain. Just going to start this, and you can now see that when you scan from forehead to neck in the patient, it's actually possible to distinguish specific brain regions quite well with this technique. If you look at the forehead of the patient here, there you see, I can point at the same time. You see the spot coming up. I'll tell you when. There you see the spot. That is an inflammatory reaction in the front temporal lobe of the patient in this case. So we believe that this technique can help us a lot and make a more powerful diagnosis in combination with what we're doing in the cerebrospinal fluid, in our blood samples, in saliva and urine. And hopefully that will lead to not only an explanation and acceptance of the disease, but also to a more powerful treatment of the patients. So by that, I just want to thank you all for your listening and for your interest. And of course, I want to thank the patients and the controls that are very much involved in our research. I want to thank our sponsors, Open Medicine Foundation, of course, the Swedish ME patient organizations in US and in UK. We also have Swedish donations now for post-COVID, specifically from the family Kamprad, and we have also anonymous private donors, both in Sweden and in Europe and in United States. And we recently also got approved funding from the patient-led research fund in United States with specific focus on long-term COVID infection and consequences of long COVID. And by that, thank you for listening.
Thank you.
I'm happy to answer some more questions if my voice can tolerate it.
Yeah.
I met my sister's lovely small kids this weekend, and they gave me something I didn't want. I think.
Not Corona.
Yeah.
We have. Thank you, Jonas, and it's very intriguing. Also, all the research you're doing. As you know, there's not much research going on in Denmark. It's pretty uphill for the Danish ME patients and long COVID patients, as I see it. I have just one question here. I'll just ask in Danish. Altså, hvis der er nogen derude, der har spørgsmål til Jonas, så skriv det lige inde i trekant, firkant og bolle under spørgsmål. There's one question here for a member. She asks, which factors separate ME and long COVID from the herpes COVID? You had a slide where the herpes was like the green triangles, and and the ME and the long COVID, they were like more together.
Yeah. There's a lot of factors actually. We measure about 1,000 different proteins in these assays. So, but generally, you could say that there is in all three groups we have inflammation, but the severity and strength of the inflammation differs a bit. And there's also repair systems that are activated, so the brain really tries to repair the damage that the inflammation has caused. And in both ME and COVID patient group, we can see that this repair activity is actually pronounced. We can see that there is you could say plasticity in the brain trying to cope with the situation. And there are other factors. There's growth factors and things that are changed also in between the different cohorts.
Okay. And we have another question from one of our seriously ill ME patients here. She says, I have ME, and is there any chance that I could join your research as a patient, or is it only Swedish patients, or have you already enrolled what you need?
Yeah, unfortunately, the system, as you know, it's a bit unfortunate that we have separated healthcare systems even in between Denmark and Sweden. I mean, we are so close in so many ways, but we still have problems. I know that some patients can come to Sweden, and we also have Swedish patients who come to Denmark for treatments in some cases. It's more tricky actually to do it, and especially when we are recruiting for research, we also under certain limitations what we can do. So most of our patients come from Sweden, from the closest vicinity to our clinic. Although when I go for home visits, we have been traveling a lot on the west coast of Sweden because there is no specialist clinic there right now. So we have been doing home visits with the patients in that region just to help them in that sense. So I guess anything is possible. There's just a matter of finding out how to do it in the best ways.
Yeah.
And I know, for instance, I know Jesper Melsen very well, and his efforts and also struggles that he has to take sometimes with with your system. But he's a very good person, and I know he cares very much for the patients in Denmark. So.
Yeah, I think he has some research coming up where he would need Danish patients, so maybe it's better to be close to that. And there is the next question is, are you worse off when you have both long COVID and ME compared to having only long COVID or ME, and why?
Yeah, that's a very good question. We don't know yet, I would say. Why we separate ME from long COVID so far is because we don't actually know what will happen with the long COVID group. How long will you keep your symptoms? How long time will it take before you recover fully, etc. So I think that's the one reason. And the second reason is, of course, that we know that long COVID group have had COVID infection. The ME group before pandemic did not have COVID. So probably related to Epstein-Barr virus, most likely, or herpes viruses, as I said. But let's see, the question was more if you are worse off. Yes, you can be worse off, but as you see, the overlap between the symptoms is very large. So it may be difficult to tell what is symptom from the ME and what is symptom from the long COVID part. I think that would be very hard to tell. But then the severity of the symptoms may increase or decrease.
Yeah.
One thing we saw that I found very interesting initially was that many ME patients in the beginning of the pandemic reported that they did not get COVID. And we thought that was something interesting. Maybe you could be protected against COVID by having ME. Now we know probably that's not the case. It's just that many ME patients are rather isolated and did not get exposed initially. So that was probably the consequence of that. Not that you have a protection against other viruses. So
yeah, I think so too. So the next question is from another patient. As you know, it's a very psychological approach we have in Denmark on ME, at least the official approach. Have you noticed any changes or interest in Sweden or abroad since the COVID came on ME? Are people more interested in ME now than before?
I would definitely say that, yes. I think there has become a change, a real shift in, let's say, mentally accepting that the COVID can lead to post-COVID. Other influences like trauma or a virus infection could lead to ME. I think that has become more accepted, although there's still some skepticism, of course, out there. But I think the openness here in Sweden has changed really fast over the last couple of years. And also you can see that there is discussions now on high level in the government that there is a need for care for patients with both ME and COVID, post-COVID patients, and that there is a need for specialist competence centers, for instance, in Sweden. I think that has been much more debated and discussed, and also open discussion around that, and acceptance is coming, I would say.
Yeah, you were in the Swedish Parliament also debating for that with
Yes.
with Professor, well, about the NICE 2021. What's his name? The psychological professor from
Brian.
Huge.
Yeah. Okay.
Yes.
Yeah. No, I think that was good. The politicians were actually very open-minded and interested, and the consensus of that was that they are going to set aside a budget for investing in, first of all, mapping out what is needed, and then secondly to create a competence center, I would say.
Yeah.
But of course it's politics and it's economy, so we don't believe it before we see it, I would say.
Yeah, well, we join the club here.
Yeah.
The next question, I think we got an answer to that. The difference in symptoms from long COVID and ME, we don't know, as you say, yet which is which, and if it's the same illness. So somebody asked now, the next question is, have you tried any form of medical treatment of long COVID, which has had any effect?
I mean, there are many trials going on now. There are some trials at NIH. And you probably heard about Paxlovid treatment trials, for instance, and so on. I think those are relevant, and we see that has had potential effect on post-COVID patients, for instance. I think still we need to wait for a fully randomized controlled study with placebo control to be able to tell scientifically that it works. Other treatments that I think is relevant, and we are luckily, we have got funding to start a clinical trial with antiviral treatment in Sweden, in Uppsala and Stockholm. That will start after summer, and we think a combination of antiviral treatment with anti-inflammatory treatment could be the way to go for, not maybe for every patient, but for quite a large cohort of the patient group. And thirdly, I would say also we are right now in the United States looking into anti-inflammatory treatment, also a combination of drugs that hopefully we will start after summer, and that will also be run at the clinical research center within our network. And hopefully the readout will be a positive effect of that combination of treatment. And we will run that also as a placebo-controlled trial.
Fantastic. Yeah. Interesting. Is it the antivirus treatment? Which antivirus are we talking about?
It will be a combination, and I don't think I can reveal yet which ones we are going to use, not to
Of course.
affect the trial. But it's not nothing super special. It's actually drugs. We are also targeting drugs that are already available. If we find something that works, it should be something that could be available to many rapidly. It should not be a research drug that no one can get hold of, because that would not help so many, of course.
And also, I heard that Paxlovid had quite a lot of side effects, so maybe something more gentle.
Yes, no, so that's true.
Somebody asked here, I have long COVID, ME, and can ME influence the lungs? I get PEM, headache, and nausea if I talk too long. So is this a typical ME, or is it a typical long COVID symptom?
Yeah, we have, as you may know, ME patients. Some ME patients report on air trapping or feeling like they don't get enough oxygen and so on. When you measure oxygen levels, they are typically rather fine, but the sensation of not being able to breathe or draw a deep breath can of course be reported on ME patients. But I would say that's more common in the post-COVID group, probably due to that some of the patients have had really injuries to the to the lung, with small microclots in the lung tissue and maybe small embolies in the lung tissue that causes this problem. And in the long COVID group, you can actually see that some of them are low in oxygenation. You can measure that quite easily. So that is not an uncommon phenomena, actually.
Okay.
Once we see that, we also try to sort the patients a bit. So patients with long COVID that have lung issues, we can also help with some medications. Patients with neurocognitive brain fog issues, we sort in another group and try to treat the symptoms based on that.
Yeah, it's very difficult to differ. So we have a couple of questions more to go. One patient here, she has ME, of course, and she's had corona twice, and both times her symptoms had become much, and then after that, her symptoms, ME symptoms, returned to their normal level. Do you have a comment on that?
I think that is a very interesting phenomena. I heard it reported not so many times before, but sometimes when you have another infection, you may reverse your unwanted immune reactivity against, let's say, an autoimmune reaction. So it seems like the immune system suddenly gets something else to work on, like another infection. And the same phenomena can occur also when you get gamma globulin treatment, because that when you give the body immunoglobulins, that seems to sometimes have an effect on reducing the overactivated immune system and helping the patient with symptoms. So maybe that's a combination, and a result of that is when you have another infection that is maybe taking over the immune system for a while, your ME symptoms could be reduced.
So,
probably not long lasting, but for a period of time.
Yes, I've heard that quite a lot of times from our members anyway. So this question is, which anti-inflammatory medicine do you use? So I guess you can't reveal that.
Not at the stage, because we are doing this trial, but there are a number of different anti-inflammatory treatments that have been tested on other patient groups, and we are trying to follow the leads of what has been tested before that we know have low side effects and is safe and is also available.
Yeah.
And then the combination of treatment is, I think, a key here, because if you only take one treatment one at a time, you will not maybe get enough effect on the symptoms to help the patient.
Yeah. Two more questions to go. One here, is the measured increase in brain pressure only due to inflammation? I think we touched this, but we can take it again. Only due to inflammation of the central nervous system? And is there any chance of getting my own pressure measured in Denmark? My main symptoms is a constant and severe headache and head pressure and headache. So yeah.
Definitely, I think we cannot say it's only due to inflammation. It can be, as I mentioned, disturbed circulation of the cerebrospinal fluid. It could be a neck issue, for instance, and so on. There's probably a combination of things. And I think definitely you could get your intracranial pressure measured by MRI or by this optic nerve ultrasound device or technique that should be available in many places. So it should be optional in Denmark also.
I don't think they do that. I haven't heard they do that on Danish MA patients, but I know they do it in Bergquist clinic. Yes.
Yeah, they do.
In Sweden, you can go there and pay for it. And last question, thank you. So in your opinion, where is MA taken most seriously right now? Is it the States, or where do you see the development going for this disease?
Yeah, that's a good question. I wish I could say Sweden and Denmark, but maybe, well, Sweden seems to take it maybe a bit more serious than Denmark still.
Yeah.
Norway have done some fantastic research, but they're also struggling with their opinions and government economy and so on. United States, I think there is an openness there. Canada also very much so. But if we want to turn into Europe, I would say Netherlands should be maybe mentioned, because the Netherlands government have now set aside a budget for ME CFS research. It's not a huge amount of money, but at least it's a good signal that this is actually something important and that should be studied. Same goes in Germany. There is a research funding for ME research. So I think it's hopefully going in the right direction. Still need much more needed to get this moving, but I'm rather hopeful.
Yes, thank you. I think we all are, and we see things moving slowly, but in the right direction, at least also here in Denmark. So I think we are all done for now.
Could I just ask one last question? Neurosurgeon, do they treat ME in Sweden, or is that only in Spain and New York?
You mean by neck surgery, you mean, or?
Yeah, neck
Yes.
surgery.
Yeah. No, it's not done in Sweden, and I know that some patients have gone to Spain, for instance, for this treatment. But I would not recommend it. I mean, it may work for a few, but it's not really a well-studied and safe procedure in that sense. It still needs to be shown and proven that it has a permanent effect. And you may cause damage also when you do that kind of surgery. So I'm careful. So I want to be I would say that you should probably be careful with that, of course.
Yeah. Thank you.
Mm.
So thank you for your excellent speech. I think we have got a lot of information, valuable information today, and thank you for taking your time to answer all our questions. We much appreciate that. So let's round up and say thank you to Jonas Bergquist, and good luck with your research. We will follow it here from Denmark, and hopefully the COVID situation will give more funding and more results for all patients.
Thank you so much, and stay well and stay in touch.
Thank you.
Thank you very much.
Thank you.
Bye.
Bye-bye.
Bye.